Thank you so much. I think first, I think this is a great opportunity to be back again here in Windhoek. Good afternoon. I think it's already afternoon here. So let me start by saying we're going to understand together how we do surveillance. I think this is very important. I've been asked to share my perspective on the role of surveillance in emerging and re-emerging diseases. First, I think we need to understand what the emerging and emerging diseases before now we apply surveillance to be able to contribute to pandemic responses. Very important. So now I have no conflict to declare. I think this is important. I think there are 4 points that I want to share with you today. The first point is around what are emerging and re-emerging diseases. The second point, there are several types of surveillance studies. I think you are all involved in some of those ones. IBS, you have heard of it, indicator-based surveillance. We've heard about the FIA survey, you recall, on HIV, for example. Event-based surveillance, some are linked to population, the genomic surveillance, and we need to look at how do we reinforce the workforce on the continent to be able to address or respond efficiently to outbreaks. So a little bit touch based on artificial intelligence because we are chronically really short-staffed on the continent. How do we leverage on that? And finally, we conclude with some point if we agree with us here. So first, stop emerging and re-emerging infectious diseases. So this is important. We're dealing with an environment where climate change have pushed us really, for those who visit their rural areas quite frequently, to the animal habitat. And that the concept of One Health actually is to bring those three together, environmental, animal, and humans. But paradoxically, on this continent where we report in a year more than 200 events, those three are separated. The Ministry of Health, they do their stuff. Agricultural, they do their stuff. Environmental, but zoonotic comes from animal. And we're always surprised when it was a very nice presentation from Prof. John Nachiga, that you see that those issues we're facing are from the environmental and animals. I think it's important that we start contextualizing it. If you don't look at social behavioral and know your ecological environment, it becomes difficult to respond. We keep saying that. Mpox is the same thing. Ebola is the same thing. Marburg is the same thing. It gets from the community and end up in New York. So we have to be very careful that we understand what's going on. So the first one, a panel on the top, gives you a little bit of glimpse of what's going on. Deforestation. Something that we don't talk about much, antibiotics, the exposure, and antimicrobial resistance is also a pandemic. I think we have to be very careful there, and it's actually happening quite frequently. I think all those stuff contribute really to be sure the exposure. You go into temper into the animal habitat, you're going to get what you get out of that. But again, this is our own way of living. On the right is a very nice graph by Tony Fauci. The red dots are newly emerging. You can see they're actually all red. So the point is, climate change is pushing us really to the reoccurrence and occurrence of some of those emerging diseases. In fact, Ebola those days, the time between, or the space between two Ebola outbreaks were like 20 years. But now it's quite frequent. And even in regions that we don't even expect to be, like Tanzania. So come on, it means that things are really moving. So this is a second stop on the background. Unfortunately, Africa is not ready. I'm going to say that twice. Unfortunately, we're not ready. And this is where things are happening. For the past 30 years, more than 30 new pathogens emerged. More than 75% from animal origin, what I've just said earlier. And every year, in 2023 alone, Africa CDC reported more than 180 outbreaks. Last year, more than 200 events. I think for event-based surveillance specialist event. And those events can be actually quantified as probably outbreak. So then 70% of those ones are zoonotic diseases. So the heat map that you see there gives you a little bit of what the situation on the continent. Most vulnerable to least vulnerable. You see where we are on the continent. We are actually really most vulnerable. So if we look at this, using the joint external evaluation of the international health regulations and analysis on 40 countries, we have 55 countries on the continent. So if you look 40 countries, you do a deep dive. This is prior to COVID. You see clearly, if you look at surveillance where actually the arrow is, you see that we're not doing well. You are not well prepared. At least 15 are doing well, the rest, that's not even 50%. So, but the rest, red. The red means that we are not really those functions. We don't actually have them. But it's important. How do we get rid of this? But now, what is actually those pathogens that we have to deal with? So this is very good representation. It's from the framework from Africa CTC on disease prioritization. If you look at the y-axis, it gives you a little bit the risk, and then the epidemic really potential. How can that spark into another COVID? That's how you can actually read that. On the x-axis, you have the disease severity. But you look there, I think we're doing pretty well a little bit on some of those, at least in terms of preparedness a little bit there globally, I think for the 55. But what is a bit striking here is cholera. How would you explain that cholera, we still have recrudescence, upsurges of cholera in 15 member states on the continent? It's back to the point we are not applying One Health. Water, hygiene and sanitation is not the Ministry of Health. You agree with me? So someone has to build and put those bridges together. But the lessons here is that there are 5 P's that I would like you to remember by the end of this presentation. Populations. You need to understand our people. You need to understand them. Don't bring intervention from somewhere and implement them in a different community X. We need to understand what people actually, their daily lives. We need to understand the pathogens. Cholera is not Ebola. Cholera is not Marburg. So we need to know exactly what pathogens we are dealing with. The policies. Are we doing more reactive than proactive? Then the politics and the partnerships. That partnership can already be at national level. If the 3 ministers are not talking together, there's no partnership there. So we need to bring them together to be able to really respond efficiently. So now the second point, the indicator-based surveillance, I mentioned it. It's an ongoing risk assessment of health facilities, could be lab-based, and then we'll talk about a little bit of genomic surveillance there, and then the event-based surveillance that we use to say we have 200 events or 100 events. That's based on, it's cheaper, it makes things easier, but the indicator-based surveillance are more expensive, and then you really have to follow longitudinally to have a trend. So what's happened during COVID? The lesson learned. This is a country of 1.5 billion people. When COVID struck, I can tell you, we only had virtually, let's say, January 2020, 0 lab on the continent that could detect or diagnose COVID-19. It's unbelievable, it's unacceptable. Then by February, then with Africa CDC, leading the response under Dr. John Kengasson, we had South Africa and Senegal. I can tell you, carrying diagnostic tests in the suitcase for a continent, it's a pity. I say that because it means that we are actually not taking this thing seriously. So you can see the progress. August 2020, the continent was green. All virtually countries were able to establish lab facility to test. Then I think you can look at the numbers, how many were tested, how many countries. But my call here for government officials in the room, how do we sustain this investment for other diseases? Leading the MPOX response after COVID-19, we had to go back from square zero. This is a little bit, the message we want to send to politicians. Let's sustain the investment during COVID. All these labs, are they still? That some of these labs are still functional. But we really want to be sure that we repurpose, we integrate for other diseases across the continent. So how do we use surveillance really to be actually providing meaningful information? So the first thing, we have to be proud for this continent as well. During COVID, Omicron was isolated in Africa, South Africa and Botswana. The first time we used genomic surveillance to be able to inform treatment and vaccination program. AstraZeneca, we told the rest of the world, is not working for us. That's the data. When Omicron arrives, we actually got the data to be saying only 10% efficacy if you're using actually AstraZeneca vaccine on Omicron. That's based on data generated on this continent, based on the investment from COVID-19, which is a good time actually, and a bad time as well for those who see things in a different way. So the Pfizer vaccine, you can see again, they reduce efficacy due to the strain. So that's why you use the power of genomic surveillance to be able to inform policy, to be able to inform treatment and then vaccination program across the continent. This is done in Africa, by African, during lockdowns. So I keep saying that. We're capable of doing things, we need to sustain some of those investments. So I'm going to move a little bit on dengue. There are two things to bring the concept of ecological surveillance. I think this is important. We have seen over time the spread of dengue across the continent. But again, all of us attribute it to presumptive malaria. And again, this is a disease where we don't have a very accurate diagnostic test for surveillance. If you don't detect, you cannot trace. If you don't trace, you cannot treat. If you don't treat, they're going to be spread transmission across board. But this data shows at least that there's over time, with climate change, it rises at least 2 degrees every single year, that dengue is actually finding its way. The mosquitoes are going to areas that they're getting smarter and smarter, to areas that they have never been, and then they spread the virus. So the third point, the stop. Now we have the technology. We have the platforms. We know what to do. We need to train people. We need to train people. If you look at this map, we are chronically understaffed. If the pandemic or the epidemic or those events start at community level, people have to identify them as an event and then alert the CDC to be able to test them. If we cannot identify them, active contact tracing, the virus is going to spread and over. So we need field epidemiologists to be able to do really a very active surveillance. If you look at this map, at least that graph on the right, we need about 6,000. And then we only have 10,000 plus. There's still a gap of 4,000. Where are those 4,000? In a continent of 1.5 billion people. I think we need to find a better way to engage with the community, make this, socialize this in such a way that we can actually make those fields very attractive. The same will apply for frontline epidemiologists. Those are the ones we need when there's a COVID-like pandemic. We turned all of us into epidemiologists during COVID. No, there should be people specialized to be able to address those issues in terms of crisis. So artificial intelligence is very important. If you have massive data, really, machine learning can be able to predict where the next epidemic will be. Machine learning could be able to predict where the areas of high burden, so that with limited resources, we can plan efficiently and address some of those outbreaks. But again, it's beyond that. There's more that we need to do. We need to invest into infrastructure to be able to use machine learning. It's not just a tool that we're going to click on. But again, predictions of pathogens, disease attribution, and then also, disease attribution, and other issues relating to predictions of or trends of a particular outbreak over time. So that we know in the next 5 or 10 years, there might likely be another outbreak in the DRC, and we prepare ourselves with that stockpile, being sure that we have the diagnostic test, all the ingredients ready, even clinical trial SOPs to be able to respond. So my conclusion, I see I have 1 minute. Surveillance play a critical role in managing emerging and re-emerging diseases by providing early warning system to detect potential outbreaks and assess impact and intervention. Surveillance also helps public authorities. I mentioned it. You can actually drive it in an area where there's high burden of a particular disease or pathogens to be able to target your response. Surveillance, again, genomics, for example, if you detect new pathogen, like pathogen X, you can be able to actually manufacture diagnostic tests, target antigen for therapeutics and also vaccines. So surveillance data can help access effectiveness of vaccination. We have seen with AstraZeneca vaccine, we have seen with the Pfizer vaccines based on genomics data. Surveillance also helps identify new unusual pathogens, as mentioned earlier, that can pose significant threat to public health. So I will leave you with this map. This is the connection. Basically, each of those dots represent an airport in the world, wherever you are. Could be in Cape Town, could be in Windhoek. You see, if the virus is there, it moves with the plane, and then there's no way you can stop it. So that is a call for global solidarity, for science, being sure that we keep science live, and then being sure that no one is actually left behind. And again, thank you so much for the invitation. Thanks, Madam Chair.